All right, so I'm delighted to be back for our fourth interview with Dr. JoAnn Manson. We've been covering a lot of ground, and today we're going to move our map forward to a little more recent years in Dr. Manson's career. And I just want to recap where we left off last time. This is in the early 90s, and you have been a co-PI on the Women's Health Initiative, running the sites in Boston, and you have been an assistant professor as early as 1991 at the Harvard School of Medicine, and a co-director of women's health and a director of endocrinology in the Division of Preventive Medicine at Brigham and Women's Hospital. And we sort of came up to a point of discussing those things last time, but within 6 short years, you are a full professor of medicine at Harvard Medical School, and you are the chief of the Division of Preventive Medicine at Brigham and Women's Hospital.
It was 1999.
Yes.
So 25 years ago, I became a full professor of medicine at Harvard Medical School and chief of the Division of Preventive Medicine. So I think it was a little more than 6 years. So
no, 6 years between where we stopped last time, and in 6 years, okay, you sort of made those moves. No, I know it wasn't 6 years ago. It was back in 1999, but it's really in some ways a tremendous, accelerated pace of your career to go from assistant to full, and from, the chief of the division. And so I thought maybe you would start us off by telling us the story of how the position of chief of the Division of Preventative Medicine came to you. Were you seeking it? Did someone knock on your door? How did you feel about stepping into that kind of role, prepared, unprepared? Just the story of how that happened.
Yes. So let me just mention that my roles in the Division of Preventive Medicine were as co-director of women's health. I was not chief of the endocrine division. I just want to
make I misspoke.
That clear as a role in the division, and then became one of the principal investigators of the Women's Health Initiative and several other studies, randomized trials related to different dietary nutritional interventions and some other randomized trials that I was involved with. The position of division chief in the Division of Preventive Medicine did become open and available, and there was a search that was undertaken for that position. And so I did apply for the position, and I was offered the position. That was in 1999, so it is 25 years. I also want to mention that I've been involved with the Brigham's Connors Center for Women's Health and Gender Biology. And this is one of the few really women's health centers around the country that's focused on research and gender medicine issues. And so originally, I had the role of being co-director of the Connors Center. Then very briefly, I became the interim executive director of the Connors Center in 2016 to 2017. That's when the executive director at that time took on a different position. So I went into the interim role, but I actually wanted to just continue to be the chief of the Division of Preventive Medicine, and really didn't seek out the long-term role. And then they did in 2017 find a permanent executive director of the Connors Center, and I am now serving as a scientific advisor to the Connors Center, and continue to be involved with the work of that program.
Okay, that's good to know. I had noted that you were involved with the Connor Center, but I didn't quite understand all the connections.
Right.
One line thing that's on a CV. So that's good to know. So when you took on the role of Chief of Division of Preventive Medicine, which you've been in now, you're still the chief of that division. What were your hopes? What was the direction or the achievements that you wanted to take the division in? How did you envision? Of course, you've been there a long while, but when you began, what were your?
Right. I really envisioned the division having a major role in conducting randomized clinical trials, population-based clinical trials that had a prevention focus, although some of the trials did focus on treatment of people with cardiovascular disease or other health conditions, but it was primarily a population health prevention focus. So that was my major vision and what I saw as sort of a unique niche of the division, in that we were conducting very large, cost-efficient, pragmatic trials. Many of these trials had more than 20,000 participants nationwide. Some of
Wow.
them had nearly 40,000 participants nationwide, and testing a large number of interventions, longer term duration. And so that was a major focus. But over time, we also have become very actively involved in testing biomarkers, biochemical markers, and multi-omic biomarkers for chronic diseases, including cardiovascular disease, cancer, diabetes, other chronic diseases. So there are many investigators in our division who focus on, for instance, genomics, metabolomics, epigenetics, which is
Yes.
a key area, and proteomics. We're doing more and more
Wow.
with that area, and
What is
measuring.
some of those I know, but what is you have to say it again for me. Proteomics.
It's the proteins in the blood, and
Uh-huh.
looking at the protein profile and signature. And there are actually many conditions that have relatively different proteomic profiles, and the different profiles can predict, for example, increased risk of heart disease, type 2 diabetes, certain forms of cancer, and looking at the proteins in the blood. And we also are interested in the effects of some of the interventions we're testing in randomized trials on changes in the biomarkers, in the
Yeah.
omics. We've looked at metabolomic changes in the small molecules in the metabolome, changes in the protein signatures. And we also have a strong interest in looking at effects on biological aging, such as through epigenetic markers, telomere length. So our division has a very large biospecimen repository,
Uh-huh.
and we have many faculty members focusing on looking at biomarkers for chronic disease and changes in biomarkers with different interventions. So that's another major focus of the division. But there are many programs around the country and internationally that do work in biomarkers and multi-omics, predictors of
Right.
chronic disease. I think what may be less, common in terms of other research programs is these very large scale population-based prevention trials, where we can cost efficiently test different nutritional supplements. We've tested aspirin in both men and women in the prevention of cardiovascular disease in these large scale trials. And also the Women's Health Initiative actually fits in really well with this focus on randomized trials, because that included not only the 2 hormone therapy trials, but also calcium, vitamin D, supplementation, the low-fat dietary intervention. But that is a nationwide, there are centers all around the country. And so I'm not suggesting that our division was the only overall director of the Women's Health Initiative, but we were one of the clinical centers.
And one of the first ones, I think you told
me.
me.
One of the original vanguard, 16 vanguard centers for the study.
So it almost sounds like as you began, you had this focus on randomized controlled trials of preventative measures and interventions, which I'm gathering was not the history of the division, that was new.
It started with, aspirin trials for prevention of cardiovascular disease, and that was early in the history of the division, but it wasn't doing as many different trials and as broad subject matter in terms of clinical trials.
Okay, and then over time, when I picture those different kind of studies, I think about the biomarkers and the cellular biological picture of preventative health. I imagine this is 2 kinds of scientists, one much more bench and blood and one more public health and data. And you would have had to sort of gear up the right kinds of skills and the right kind of people to be able to do both. Was that a big part of what it meant to keep the division moving with the science on prevention?
We do have faculty with a broad, array of skill sets. We have several biostatisticians in the division. I think most of our researchers are epidemiologists and population health researchers, as well as clinical researchers. We don't, in our division specifically, have bench research wet labs, though we do have the biorepository where we store samples, millions of samples from all of these studies. We have a lot of participants across the different studies that have been done, and they can send them out to different labs across the country, across the world to measure the biomarkers.
Okay, when you said the repository, I'm picturing wet labs and these kind of things. So I was wondering, that helps my visual image match.
It's really more of a freezer, repository. We have all of these blood samples and some urine samples that are stored within liquid nitrogen freezers, a very large, resource where we have all of the.
I would imagine, because the size of your trials are large, so these samples would be huge.
It's a lot of space storing the biospecimens, but we also really encourage collaborations with researchers across the country and even internationally to, for example, leverage some of these resources to measure biomarkers that are of interest to them.
And their research is advanced understanding the large-scale epidemiological side.
Very often their research is focused on, major chronic diseases like cardiovascular disease, cancer, type 2 diabetes. We're increasingly interested in the subject of cognition and prevention of memory loss, cognitive decline. So we've done more and more research in that area, also collaborate with many groups studying dementia, ways to prevent dementia and to predict dementia. So that's another area we maybe can come back to later, because we actually are really interested in exploring a particular intervention that has shown some promising results for slowing age-related memory loss and cognitive decline.
Okay, that sounds wonderful. Over the years that you've been there, are there accomplishments during your tenure as director that stand out for you, the things that you're like particularly proud of or glad that you were able to achieve? What would you say some of those have been?
Yeah, so first, the Women's Health Initiative in terms of participating as one of the principal investigators, I feel very good about the information provided from that study just in advancing women's health. It was an increasingly common practice to start hormone therapy in women, often in their 70s, even 80s, for prevention of cardiovascular disease, for heart disease prevention, stroke prevention, trying to reduce risk of dementia. I think we showed that, at least in the older age groups, that practice was not optimal, and that hormone therapy still remained a very appropriate option for management of bothersome hot flashes and night sweats in menopausal symptoms in early menopause, as we talked about last time.
Yes.
We've recently tried to kind of synthesize what the clinical messages are for healthcare providers, as well as women at large in the population. Another study that I've been very actively involved with, a principal investigator of, is the vitamin D and omega-3 trial. This is a large scale, more than 25,000 men and women in the US nationwide. And it is a very diverse study population. We actually made it a priority to enroll at least 5,000 African-American or Black participants, because we were really interested in whether vitamin D may be of special benefit in that population and could reduce some health disparities. So we made that a point. We have a diverse study population in VITAL. And I think that that has been a really, strong advantage, to be able to look at many factors across educational level, race and ethnicity, across socioeconomic status, regional, geographic areas, health insurance, coverage, issues.
Right.
So we've been able to look at a lot of questions. Now, in this trial, our main findings were that we did see that vitamin D supplementation, we tested 2,000 IUs a day. And by the way, we mail out calendar packs. They're like blister packs that contain the study pills, and makes it very easy for the participants. I mean, not that easy, but easier than with a bottle.
Easier.
To remember to take their pills, and they also can report to us more easily if they missed, some of the study pills. So in this large scale trial, which lasted an average of 5.3 years, we found that vitamin D supplementation did reduce the risk of advanced cancer, metastatic or fatal cancer, a reduction of about 17%. And we also saw that there was a significant reduction, at least in the initial analyses, in autoimmune diseases such as lupus, rheumatoid arthritis, psoriasis, conditions like that we've continued to explore. We also found some interesting what we call effect modification, when we do the analyses stratified by certain factors, such as looking at people of different body mass index or different body weights. We saw that there was a modifying effect of body weight and adiposity, that in some ways higher body mass index was counteracting some of the benefits of vitamin D, and those at lower body mass index had greater benefits. And we want to delve much more deeply into these findings, because they may provide insights into how to make vitamin D of benefit to all, across all BMI, body mass index groups. And we think we have some clues and some insights at this point that may be helpful, but we need to continue to look at these questions. But the main benefits were for advanced cancers, cancer death, and also autoimmune diseases, and this modifying effect for some of the other outcomes as well, by body mass index. There
Right.
are other randomized trials of vitamin D that have suggested that vitamin D is of particular benefit in preventing cancer death. And we've done what we call meta-analyses, looking
Yes.
at these different trials in combination and seeing, significant reductions in cancer death when these different trials are combined. So I think this finding in the VITAL trial of the reduction in advanced cancer, metastatic or fatal cancer,
Yeah.
is borne out by some other randomized trials. We need to delve more deeply into mechanisms to really try to understand those findings. Then some of our other findings from VITAL are that—
Well, let me just ask one question about the cancer one before you go on. Is this clinical practice yet? Are you doing the messaging so that this is vitamin D in cancer patients is now, I don't know, is it clinically taken up yet? Or is it not ready for that kind of messaging yet? What's your thoughts?
It's really starting prior to a diagnosis of clinical cancer. So what's interesting is that it remains controversial whether vitamin D supplementation, once cancer is already present and diagnosed, whether you can get a substantial benefit from taking vitamin D supplementation. There are many research groups looking at that very question. What our study was looking at was starting vitamin D supplementation in those without a history of diagnosed cancer or cardiovascular disease, and then seeing if vitamin D or the marine omega-3 fatty acids, EPA, DHA, as in fish, the omega-3s, could prevent development of cardiovascular disease or cancer. And so with the vitamin D, we saw that if you start it before a diagnosis of cancer, it seemed to be reducing the risk of developing an advanced cancer. It may be because vitamin D has an effect in preventing the deep invasion of cancer cells and cancer into the tissue, and makes it less likely to become metastatic once it's present. But if the cancer is already metastatic or already advanced, then you may not have the same benefits.
I understand.
It's an area of active research.
So is it clinically, are GPs and family doctors telling people to take vitamin D? Has that moved out?
There are not yet clinical guidelines to do
That's what
this
the word is that I'm
routinely.
looking for.
And in fact, if anything, I would say that the recent randomized trials have somewhat tamped down the enthusiasm about widespread supplementation with vitamin D, because there had been tremendous enthusiasm, even very widespread screening for vitamin D deficiency. And a lot of the clinicians were screening and starting vitamin D supplementation. And then some of these randomized trials got started, like for the VITAL trial and Do Health and several other vitamin D trials. And the randomized trials are not showing widespread benefits. It's not like a cure-all, a panacea to prevent every chronic disease. It's really a more limited benefit. And we still think that people require only small to moderate amounts of vitamin D, and many people get that amount just from diet plus incidental time outdoors, the sun exposure and synthesis in the skin. But particularly older adults tend to need more vitamin D, and they have decreased absorption, decreased synthesis of vitamin D in the skin. So I think, again, it may come down to this precision nutrition. It's not one size fits all.
Just like the menopause and the hormone therapy, it has
exactly.
Yeah, targeted messaging.
So we think that Vital has helped to answer some of the questions about vitamin D. And then in terms of the marine omega-3s, we are seeing that there's a reduction in heart attack. There's a reduction in coronary heart-related events, but there's no reduction in stroke and no significant reduction in the combination of heart and stroke events, which is often called major cardiovascular events. So again, even for the omega-3s, and we tested a moderate dose of 1 gram a day, we saw that it was not of benefit to everyone. It was not of benefit for everything. It was seemed to be a benefit overall for reducing heart attack. We found that in those who started out with lower fish consumption, if their nutrient status for fish and omega-3s was lower at baseline, then they tended to benefit more. And they actually did have a significant reduction in the primary endpoint of major cardiovascular events. It was somewhat complicated. This was another intervention where our participants who were the African American and Black participants in our study tended to benefit more from the omega-3 supplements than the other groups. And they also seem to benefit for certain outcomes more from the vitamin D. So that's exciting to us because, you know, we did really try very hard to have enough statistical power to look at those questions in Vital and see if that group benefited. And so we want to pursue the findings that we have in Vital with additional research.
Research, yes. Yes, it's a health equity question if you can solve some of the disparity that exists.
Right. I mean, we think that it may have a role in at least narrowing some of these health disparities in cardiovascular disease, some of the chronic disease outcomes. So, you know, we're excited to do additional research in that area. We
That's
had
fabulous.
another large-scale trial.
Okay.
But the Vital was funded by the National Institutes of Health, and we had multiple ancillary studies. You know, this is another thing that I feel good about in terms of the large randomized trials, that because it was such a large trial and we were able to continue the treatment for more than 5 years, we were able to look at many health outcomes beyond what we initially planned. So the primary outcomes were cancer, cardiovascular disease, but then we were able to provide opportunities for other researchers, both within the Brigham and Mass General, Harvard Medical School, as well as at other outside institutions to collaborate and pursue their own interests and look at outcomes such as type 2 diabetes, depression, change in mood, change in cognition, autoimmune diseases, osteoporotic fractures, you know, many other outcomes. And this, we think, was helpful not only in advancing the science and in what could be learned from this resource, but also was very helpful to the careers of faculty members who were able to take the lead and become principal investigator of an NIH, you know, R01 grant related to this topic. And a lot of them became even more interested in randomized clinical trials, which was exciting, you know, in thinking about future collaborations. So we had opportunities for quite a few researchers in the division, as well as outside of the division, in the general, Mass General Brigham, Brigham Women's Hospital, Mass General, and Harvard Medical School, you know, the broad area, as well as outside institutions.
It sounds like part of the thrill of large randomized controlled trials is the life that research can take on beyond what you had envisioned when you began the trial. That would be
Absolutely.
thrilling. It has its own organic life.
Absolutely. But not all trials are large enough, or,
Uh-huh.
we were able to develop a lot of resources in the trial, collect bloods, have
Yes.
stored bloods on most of the participants, have clinic visits where we did very detailed in-depth phenotyping, testing cognition, evaluating mood, body composition, doing 2-hour oral glucose tolerance tests to evaluate glucose tolerance and diabetes risk. So we were able to do a lot of different evaluations and assessments of the participants, and this has provided, together with the questionnaire information that they provide, the participants provide on a regular basis, a lot of opportunities for researchers around the country. But I just want to make the point that we are tremendously grateful to the volunteers who
Uh,
participate in these research studies. It is really such a gift to, the population, to science, that the study participants, these 25,000 participants around
yes.
the country.
And it isn't as simple when you outline the clinical work that goes with it and the monitoring over 5 years. This is not a small,
It's
I took a pill for a week and I'm done. This is a huge commitment.
exactly, it's not a
Mhm.
small ask. And
Yeah.
they are just so generous with their time, and they really are are very often just interested in helping to answer these questions, even if they don't directly benefit. And they're willing to take a study pill for 5 years. They don't know if it's an active,
Right.
dietary supplement. They don't know if it's vitamin D or a placebo. They don't know if it's omega-3s or a
Yes.
placebo. It is just incredibly generous. So I really do want to acknowledge that. I always try to acknowledge the volunteers in the study whenever I give a talk about the research, because this research cannot be done without the study participants, and it's very often volunteers. Or if they do get some compensation for something that they do, like giving a blood collection or coming in for clinic, it's a very small compensation relative to the
To the ask.
actual contribution that they're making and the gift that they're giving in helping to answer these questions.
It's phenomenal when you think about it, that learning about prevention is a whole science that involves a whole public. You
Yep,
really can't learn without these large public contributions from ordinary people, most of whom are not even sick yet. So as you say,
exactly.
this is not for their own benefit. It's a huge, you make me realize 25,000 people over 5 years. It is a tremendous contribution to science.
I mean, it is extremely altruistic, because they're not looking to have a specific health outcome treated, that they already have, or to get access to a specific treatment that they might not have elsewhere, which is also very
Yeah.
generous of people to participate in treatment trials and, take the chance of getting a placebo. Um,
Mhm.
but here it's generally healthy people who don't have these conditions, and they're just trying to help get answers to the scientific questions of whether these interventions can prevent first development of
Yes.
cardiovascular disease, cancer, type 2 diabetes, many other outcomes.
And you couldn't know the answers to your own scientific questions without them.
Not
So that's
without
pretty
that,
fascinating.
not without doing the study.
Yeah.
It's many years. You have to be patient doing research like this. The answers don't come overnight, And even when the intervention ends, there's a long period of continuing to collect medical records to,
Mhm.
confirm the endpoints, getting consent for medical record review from the participants, for doing analyses, writing papers, getting papers published. It's a very long, extended process. So you have to be extremely patient. We also, you were asking about other trials and other studies. We did a large scale trial called Cosmos, which is a cocoa
Mhm.
supplement and multivitamins outcome study. And
Yes.
was looking mostly at cocoa extract in terms of cardiovascular disease, and multivitamins, mostly in terms of cancer, where multivitamins had previously shown, even in our own Physicians Health Study 2 trial, had shown some promise for reducing risk of cancer that may be related to the vitamin D and other micronutrients, in the multivitamins. So we did this trial. It was a shorter trial, lasted 3.6 years. We found some interesting findings for the cocoa extract in terms of cardiovascular death being reduced, and also very promising signals for overall cardiovascular disease. We want to follow up with a second trial to see if the cardiovascular outcomes are of benefit. And we also saw a suggestion of some benefits of the cocoa extract for cognition
Really?
and slowing age-related memory loss. And with the multivitamins, ended up being really too short a duration. The 3.6 years, probably too short to look at cancer and cancer
Mm.
death. But we had some very exciting findings from Cosmos that the multivitamins slowed age-related memory loss and
Mm.
cognitive decline in 3 separate placebo-controlled studies within Cosmos. And then we did a meta-analysis combining these 3 separate ancillary studies. And in these ancillary studies, cognition was being measured using different methodology.
Right.
It was being done by telephone assessments, by web-based online assessments, as well as more of a gold standard in-person, very detailed cognitive assessment. And all of these methods were showing a signal for multivitamins slowing age-related memory loss and having some cognitive benefits. And so in the meta-analysis, we found, very strong, highly
Okay.
statistically significant benefits for age-related memory loss, as well as global cognition. And we want to follow up on those findings with
Right.
additional studies of multivitamins. We know nutrition is so important for optimal brain health,
Mm-hmm.
and it could be very exciting if multivitamins can be of help, especially in older adults. All of our participants were age 60 and older.
Right.
And so, I certainly want to highlight that dietary supplements
Yeah.
will never be a substitute for healthy diet or healthy lifestyle, but it may be a complementary approach. And these findings suggest that the multivitamins did have a role in slowing some of the, age-related memory loss and cognitive aging among people 60 and older. So we want to look even at some younger age groups,
Right.
see if there are benefits there, and also see if these findings can be replicated in a
Uh-huh.
completely separate study.
I can see your excitement for now looking at dementia, which hasn't historically been what you in the division were most focused on. But I mean, when people talk about a tsunami of aging and
Right.
age-related dementias and Alzheimer's, I can imagine the public health impact of some of these things. if they
And we're
come to.
collaborating with other investigators who really focus their careers on
Right,
dementia and cognition. So it's a really good synergy and collaboration because we can provide the randomized trials and the cognitive
right.
assessments. Yeah.
So I had, sort of been hearing about these things as things you're particularly excited or proud of over your tenure as director, or chair, sorry, of the preventative division. And I'm curious to know, what were the difficulties, the challenges, the things that kept you up at night scratching your head as you've tried to move these projects forward?
Well, it's always a challenge getting funding
Ah,
for
okay.
these studies. These are very expensive studies compared to
Mhm.
like your more typical grant would be maybe 1/4, 1/5 the cost per year. And so very often it is challenging making a case to review committees that this is an important trial to do, that is worth, this larger budget. Even though we do extremely cost efficient trials, and our trials are even 1/5 to 1/10 the cost of some of the other trials that, are often done by industry or some of
Yes,
these treatment trials. It's still expensive in comparison to your more, typical cost of a typical budget for a grant. So I would have to say that sometimes lose sleep over getting grants funded and keeping the division running because the infrastructure of the division is heavily dependent on having, sources of funding, being able to support staff. We never want to have layoffs
right,
of staff. So to keep funding for them going, we need to get new infusions of, new studies going, long-term follow-up. Sometimes after an intervention has ended, it can be challenging to get the long-term follow-up after the trial, to
mhm,
see, because there are some findings that emerge longer term. We've had some really interesting findings recently with the low-fat dietary pattern in the Women's Health Initiative with longer-term follow-up. Like
ah,
after 20 years, there was a reduction in breast cancer death. And so, sometimes the very long follow-up will provide additional results of interest. And so maintaining funding is always a challenge. Promoting faculty, we are very happy about our division has a good track record of getting faculty promoted. So we have a very large percentage of our faculty who are full professors or associate
okay,
professors, higher than many, many other divisions. And, that's good in that, it's helpful. These resources that we have, mentorship helps to advance the careers of faculty, and that's a major mission. That
right.
mentorship and educational mission of the division is really important. But you worry about some of the early career faculty. Are they going to be able to stay funded, or will they end up wanting to leave an institution where it's mostly soft money? They need to get grant funding. There are opportunities in industry,
Right.
a lot of opportunities in the
So
Boston,
retention
Cambridge.
and the ability to keep people moving on their career paths.
Right. So,
Yeah,
you know, helping especially the early career faculty advance their careers, providing the mentorship to help them with that,
right.
helping them to get grant funding so that, their careers will advance. These are all challenges. And actually, everything has gotten more difficult over time. I would have to say that
That,
in the last 5 to 10 years, there's less funding available for some of this research, it's more of a challenge to get, especially large randomized prevention trials funded. Some of our collaboration, or private, public, academic, collaborations, some of those are more challenging. So these are the kinds of things that are difficult.
Yeah, I was going to ask you about that as you were describing things. I was going to say, has the funding climate changed? And yes, I'm hearing that it has, but has it changed especially for preventative health research, or has it changed for every kind of health research? Or are you seeing like different elevations in the landscape of who gets funded and who has less funding available in terms of the kinds of things you research?
Yes, I mean, I think it's a good question. I've seen the funding be a challenge for many departments and divisions. So I would have to say more broadly, there are challenges. But I think when you have the division is based largely on very large randomized clinical trials that require a lot of resources and support. There may be some additional challenges with that. So it's difficult, and I certainly have lost some sleep over it at times. But I'm staying really optimistic. We have several new ideas for randomized trials. We're excited about the ideas and pursuing funding for them. And if even half of these ideas were to end up being funded, we're hoping even larger percentage than that, but that would not be bad.
Yeah, half would be a stellar record, I would think.
Would not be bad at all.
Good. Okay. Well, I was curious about that. I also wanted you to maybe reflect on, we've talked about each stage of your career, what it was like to be a woman and a minority as a woman. And now you're in leadership roles like the one you're describing and making these decisions. And I know you were the first woman chair of the division.
Of the division. Yeah.
Sorry. Yeah. And
I mean, the division isn't that old, but yeah. Okay.
Right. But I would imagine you were one of few women chairs of a division. And in general, in terms of being a leader in health research and health education, academic medicine, I know that women are not at par in those leadership roles the way they are becoming parity in other kinds of student roles. So what was that like? Do you feel there were unique challenges you faced as a woman leader? We've talked about in your past career, you often felt this is individuals. It's not a structural sort of thing, but I'm wondering as a woman leader, how you envision the special challenges to women and whether or not this is a bad egg here and there, or if this is something that needs more systemic attention to help women achieve parity.
I think it does need some systemic attention. I think that the burnout rates among let's say healthcare professionals and really any of these physician scientists and researchers tends to be very high. The burnout rate among clinicians, those who focus on clinical practice, tends to be quite high and higher among women than men. And that has been seen in a number of studies. So I think we do need more attention to the challenges of juggling, work and life, the work-life balance challenge. And also women continue to have the majority of the childcare responsibilities in most of the cases. And so this is a real concern, that for women to be able to juggle all of the responsibilities of an academic career, certainly a physician scientist where you're trying to blend clinical work and research and
Right.
any leadership role, it is very, very difficult. I mean, the hours are very long, and there isn't the kind of support system that you really would want to see in place. But, I think that our institution tries very hard to help with this, and they do provide
Mm-hmm.
a lot of resources. Um, childcare remains a very, very great challenge,
Yeah.
pretty much throughout the country, and certainly in the area where I am. But I think that we do need more attention to this issue. I feel like it is really gaining some attention. It
Okay.
is clear that there are fewer women progressing to associate professor, especially full professor
Mm-hmm.
academic ranks, than would be expected based on the number of decades since there's been relative parity in
Right.
number of medical school graduates who are female versus male. You would think that leadership positions
The
and
pipeline would have delivered by now.
the percent who are full professors, it would have delivered by now. And the numbers are much lower in women. And especially when you get to positions, chair of a full department, like a department of medicine, a department of surgery,
Yes.
um, there, there's a very big difference in the percentage who are women versus men. So I think a lot more work needs to be done in this area. I think some of it really does need to be institution specific. I don't know
Mm-hmm.
that mandates coming externally will help that much, but a big issue also has been even something as simple as salary parity
Ah,
on
uh-huh.
equity, um,
Mm-hmm.
that when it was really looked at, when it has been looked at really carefully, just as in the general workforce, there there
Yep.
are these salary gaps where women are so disadvantaged in terms of wealth and their average salaries and accumulation of wealth over time. I think this is not something that medicine and research and science is completely immune to. I think that there are
Right.
some salary equity issues that also go on within that field. So it needs more attention, it needs more awareness. I think especially the concerns about burnout rates and
Yes.
many women going to part-time because they are so burned out
And
by
can't imagine a life that makes sense. Yes. Yeah.
trying to juggle so many responsibilities. Um, but I do think it's really important for partners to be supportive and to step up to the plate and really share in childcare and share in some of the make work-life balance more feasible for women.
And for you yourself, JoAnn, when you were sitting as a leader in these positions, did you have to argue for salary parity? Was your partner supportive? Do you get overlooked for those kinds of promotions, or were you seen as promotable? For you yourself, did you have to fight some of these battles? Did you feel like if I don't advocate for me, these things will not happen? Or did they just unfold?
I I didn't feel like I was really, really actively battling
Okay.
against the
Okay.
system. Um, I think that, our institution does try very hard to have parity and equity. They work very hard on that. There also has been an initiative on salary equity issues, that is more recent, but real attention to that. We really try to pay attention to that in our division, and I think pretty much throughout the Brigham and Department of Medicine, there's a lot of attention, and maybe even throughout the Mass General Brigham system more widely, there's a lot of attention to that issue. So I don't want to make it seem like it was a breeze, everything wasn't just falling into my lap. I felt I had to work extremely hard for everything that came my way.
Right.
But I also couldn't point to that many examples where it was really being treated unfairly.
Okay.
But we do try very hard to be equitable, in a lot of the decisions that are being made about leadership opportunities and salary in the division. But I think it really has to be, I think individual leaders really have to prioritize that and make
that was my next question. As a woman leader and one of the first as chief of the division, have you yourself been giving special attention to these questions of gender parity, inclusivity, work-life balance? How have you been an advocate for the things you recognize as being sort of systemic? And now that you're in a position where you have some authority to move some of that agenda forward. Or I'm assuming you do. Maybe you don't. You have to tell me. But yeah, how have you been?
I feel that I have actually really prioritized that, but I don't want to do it to the detriment of male faculty. I would be concerned about them as well. But I will say that we have a really, really high rate in our division of women faculty being promoted to associate and full professors. And I've made that a real priority, that we don't delay, once there is, let's say they've reached a critical mass of accomplishments and publications and research, that I try not to delay at all and just move people forward to promotions. And so we do have a really, really good record of, in terms of the percentage of women faculty in our division who are associate or full professors. But I don't think it's been at the expense of the male, because I'm also paying attention to putting them up for promotion when appropriate. But I think that what can sometimes happen is that in some programs, I'm not saying it happens at the Brigham or Mass General. I think, in fact, it may be less likely to happen here, and maybe more likely to happen in some other programs. There is women faculty can feel like they've been overlooked for promotion. They feel like they really have that critical mass of research achievements and publications, and someone who's more junior than them with fewer accomplishments, who's a male, just got promoted to associate. And because the division chief and department chair play a very big role in the promotion, putting people up for promotion, it is important to constantly be keeping that in mind, that you don't in any way disadvantage one group compared to another. I really make it a priority that faculty in our division, once, in my regular meetings with faculty, we go through their CVs and look at the various accomplishments, publication record, and see if they're ready for promotion to the next stage. So that is something that is really important to me. And I think we're doing a good job in that regard.
Right. I don't doubt it, but I just wondered how being a woman in that chair of the chief has helped avoid some of the overlooking, some of the dismissive kinds of positions, I think.
And salary equity
Yes.
issues, also really keep an eye on that to be sure that there aren't the
These
disparities.
marked
And,
disparities,
you know,
yes.
we have pretty good evidence that there aren't any inequities by sex in our division.
Right. Yeah, and I realize we're just a little over 3 o'clock. Do you have a little time for me to ask some questions about mentoring, which I think in your last answer, I get a sense of how important mentoring the careers of others has been for you, but I'd love to hear you elaborate a little bit on that
Yeah.
because you mentioned it before and you mentioned it today, and being a mentor to others, maybe particularly women, maybe everybody, maybe early career, I don't know. What is the world of mentoring meant to you as you've sort of achieved the kind of ability to sit in positions and be a mentor?
I mean, I feel like when you become a more senior investigator, faculty member, and are in a leadership position, it is just tremendously important to prioritize mentoring and helping the early career faculty, early career trainees to advance in their careers. I actually consider it a tremendous honor to be able to have that kind of role in
Mhm.
lives of many of the faculty in the division, that I can really advocate for them. I can work with them to see how I can help, you know, advance their careers, help them with grants, you know, get grants funded, help provide opportunities to speak at meetings, to become members of a professional society, to win
Right.
awards, sponsor them for awards, and just really help in whatever way I can to advance their careers. You know, in some ways, it has an analogy with what I was saying in the earlier, you know, discussion about the way I feel about clinical practice is that it's such an honor
Mhm.
that patients
Mhm.
will entrust a doctor with their care, you know, and they will be confiding. No, I feel like it's such an honor that they're entrusting me with their care and
Yeah.
that they're confiding so much in me. I feel it's somewhat similar with
I see.
mentees, that it's an honor, it's really a privilege to be able to play an important role in their lives, in their careers, to help, you know, help them develop into as successful a researcher, investigator, clinician, and previous work as they can be. So I feel that I'm very committed to mentorship. It can be a substantial time commitment, and I won't deny that. I think that it's very rewarding and gratifying to do it, but it can require, you know, large amounts of time, which I'm more than willing to do. But what ends up happening is that your schedule does not get lighter, you know, because
Right.
some of the things that you were previously doing and focusing on, you may be able to do a little less of those things, but it gets replaced by
Right.
attending meetings, serving on search committees, you know, promotions committees, and doing a lot of mentoring and teaching. I do some teaching over at particularly teach some give lectures at the Harvard School of Public Health, and I was one of the directors of a course at Harvard Medical School on sex and gender informed medicine that
Uh-huh.
we got started about 3 years ago, which was very exciting to develop the curriculum along with my colleagues for that course. And it was, of course, third and fourth year medical students. It was a big time commitment, but it was very rewarding. And so I do some teaching, especially lecturing in different courses and then directing that course, co-directing that course. But most of my work with trainees and early career faculty is in the mentorship role,
Right.
as opposed to a tremendous amount of in-class teaching.
Right. You know, I'm just thinking about the course you developed on sex and gender medicine. And it's almost full circle, isn't it? Because I remember you telling me about being a medical
Right.
school student and recognizing the gaps in the curriculum that just didn't address the female body as an entity of
Right,
difference between the male
right,
model. And there you are later in your career, actually
exactly.
developing curriculum. You know, it really is a wonderful kind of arc to think about those
Yeah.
early, you as a student and now you as someone setting curriculum for students.
And I did think about that a
Did
lot.
you?
And, you know,
Yeah.
often with the co-directors of the course, we would talk about, boy, we wish there had been a course like this for us when we were in medical school,
Yes.
because this is just the kind of course. Let's develop a course that we would have wanted to have when we were in medical school, but it was not like that. You know, there wasn't teaching of that nature. You know, it was
Right.
focused not only on, you know, women's health and sex differences in medicine, it also had a focus on LGBTQIA
Right.
health and that area. And so it was providing education in an area that most medical schools do not provide that kind of training in.
Right. Yeah. I mean, it's fabulous to think about the arc and then to
Yep.
think about you coming back in and changing things for a new generation of learners and practitioners and researchers. I think that's brilliant. I am cognizant we are running over. Do we want to leave a set of questions for next week or we can keep going? It's
How
you tell
much
me.
time, how much time do you think we would need for discussing the other questions?
Yeah, I would say 20 minutes to half an hour because I have some questions about your involvement with professional organizations. I'd love to hear more about that, about your overall contributions to our knowledge of cardiovascular disease, and then sort of some reflective questions about looking back and looking forward. So a
So
little bit more.
how do you feel about continuing to go for that period of time?
I'm game if you are, but you're the one who
I
has to
will
be
need
correcting your
to
thoughts.
make a quick phone call to find out
So
if someone needs me for something, but I will be right back.
that sounds like a good plan. I'll pause the recording and you do what you need. Wonderful. Okay, so we were just speaking about, you know, the different roles you've played in teaching and mentoring. And one of the questions I wanted to ask you was, you've had a lot of involvement with different professional organizations. The American Menopause Society, you were the president in 2011, 2012. I know you've done a lot of work with the American Heart Association because I read in one of their statements that much of what we know today about women's health and cardiovascular disease is a result of Dr. Manson's pioneering efforts.
Well, that's
And
very
I
kind
wanted,
of them. Very kind
yeah,
of them. I don't
well,
know
it's,
that I would necessarily agree with going that far, but
yeah,
anyway.
well, they certainly felt that. And I wanted to know if you might want to reflect for a minute about women's health and cardiovascular disease today. What do we know that we didn't used to? What are the key findings you've contributed to? And what remains to be explored? So I'm interested in cardiovascular disease and just that, you know, a wonderful statement from the American Heart Association, who I gather has been a partner for some of your research for some time.
Well, cardiovascular disease is still understudied and underappreciated in women in terms of women's health. It is very surprising that the leading cause of death in women would be so understudied, and that women themselves would often not be aware that cardiovascular disease is their greatest health threat. And many of the surveys show that when women are asked about their greatest health threat, many times they will say breast cancer, even though 6 times as many women die from heart disease each year as from breast cancer. So the awareness level is low. Women tend to have delays in seeking medical care. They tend to, get have more advanced cardiovascular disease by the time of diagnosis. And very concerningly, they're less likely to receive guideline-directed care, to get statins for lowering cholesterol levels, to get good control of blood pressure. They have a higher rate of dying after a heart attack, especially younger women have higher case fatality from heart attacks and coronary heart disease. So there are a lot of concerns in that area. I think that the underappreciation, it's not just among women, it's also among clinicians are often not thinking of heart disease as also a woman's disease, and women are just less likely to there's even some evidence they're less likely to be taken to an emergency room by with the ambulance siren going and lights flashing.
It's not a crisis moment in the same way.
Right. So it's less likely to be believed to be due to a heart attack, what with the symptoms going on. And often there's delay in getting medical care. So, there are those issues that are really concerning. We know that women have some differences in symptoms. I mean, chest pain is still the most common symptom in both men and women, but women may be more likely to have some of the atypical symptoms, pain in different areas, including, jaw, neck, and also nausea, shortness of breath. Some of those symptoms may be more common. So symptoms may be a little different. There needs to be a better recognition of that among women and the clinician. Clinicians may be caring for them. There are many other differences. Diagnostic tests have different reliability in women versus men. Women have certain, there are some differences in terms of risk. Women are more likely to have small vessel, what's called microvascular disease. They're more susceptible to stress cardiomyopathy, which is believed related to surges of stress hormones such as adrenaline. They're more likely to have a type of heart failure called heart failure with preserved ejection fraction, for which there's less known about ways to treat it and to improve outcomes. And women are more susceptible to that type of heart failure. Women are more likely to have strokes when they have the condition called atrial fibrillation, where there's already an increased risk of stroke, but it's particularly high in women compared to men. They're more likely to have death from cardiovascular disease in the setting of atrial fibrillation. So there are a number of these differences and very little research. And this is just a small sampling. There are many other differences, but very little research has really focused on understanding sex differences in cardiovascular disease and understanding ways to improve care for women in the prevention, diagnosis, treatment, and ensuring that some of these conditions, such as heart failure, preserved ejection fraction, atrial fibrillation, stroke risk, are directly addressed in terms of ways to improve outcomes. Very little known about the microvascular disease. How do you actually treat that and help to improve prognosis of women? Another issue that is really important is that there are certain stages of life that provide windows into a woman's cardiovascular risk. And generally, very little is done to take advantage of this. For example, we know that complications of pregnancy, such as preeclampsia, hypertension in pregnancy, and gestational diabetes are major, risk factors for cardiovascular disease or type 2 diabetes. And very often women with that history in pregnancy aren't even like fully aware that they have that history, and it's not often asked about by the doctors taking care of them after the pregnancies. And this should be at least a marker of increased risk. These complications of pregnancy should be understood to be a marker of increased risk, if not directly contributing.
Right.
But there needs to be even more vigilance about modifying lifestyle behaviors, controlling blood pressure. If a woman had preeclampsia, she's at very high risk of developing hypertension, persistent hypertension afterwards, and of having an increased risk of cardiovascular disease, heart failure. So it's really important to control risk factors, control blood pressure, control cholesterol, control blood sugar if diabetes develops, and monitor these women more closely for preventing cardiovascular disease. So these are just a few of the areas where I think so much more research is needed, but we already know there are these differences. And the research is still so limited on how to provide sex and gender informed care for, in this case, specifically for women and these conditions that are really either specific to them or predominant in them.
Yeah, I listen to you talk and I think, I knew symptoms for heart attack were different in men and women, but the range of things you describe as different, I certainly wasn't aware of. And when you talked earlier about the funding challenges for research, what is the climate for women's health research today? I know, early in your career and around the Women's Health Initiative, there was a bit of a political movement to put women's health on the agenda at the federal level, at the NIH, and where does that sit today? Is that part of the reason we know all these differences, but we don't know what to do about them or how to mitigate them?
Well, there has been some funding specifically allocated to women's health in the current administration, and some requests for funding. Some of those requests will have to be approved by Congress and, go through the whole political process. The overall amount of funding is quite limited compared to, when these different studies have looked at how much funding is allocated to research for conditions specifically in women or predominantly in women compared to how much funding is allocated to conditions specific to men or predominant in men. There is a big difference. And definitely there's less funding for the women specific or women predominant conditions. I think that there is a movement toward changing that. There's a lot of advocacy and activism toward changing that. But we'll have to see. Time will tell how much of that will translate into actual major funding initiatives and changes in the healthcare system, which right now, it has a lot of issues, a lot of issues. And I think that, very often women may feel that their questions and concerns aren't being addressed. We talked about menopause. We talked about how rarely women will be asked questions during their visits or, really be given an opportunity to discuss some of those concerns that they may have and how many women are having difficulty finding a clinician who is really fully informed. We're very much informed about menopause and options, hormone therapy, other options for treatment, not so much to prescribe hormone therapy for everyone, but to have a conversation and to help in the shared decision-making process. I think when women can't get these answers, they feel that, they may be missing out on really important opportunities to improve their quality of life, improve overall health. So it is so important to bring all of this into the conversation.
Yeah, thank you for that. And, as you're talking, I'm thinking the record of publications in your CV is exceptional. Everybody comments, one of the most cited researchers and among the very top cited women researchers. But I also know you've had a very active voice as a population health leader, publishing popular books, publishing regular columns, trying to educate the end user of our healthcare system, and as well as the clinicians and the scientists. What made you take on that role of advocating in public for what we know and what people should be aware of around exercise, supplements, menopause? I mean, your publishing record just on the public side is extensive. I'm not going to even touch the scientific side. We'd be here for 2 days. But, can you tell me something? Not every scientist and not every leader of scientific research spends as much time, energy, and effort in educating the public as I know you've done. So I'm very curious to know how you see yourself in that role, when you started to see yourself in that role, why it matters to you. What was the story? Did a publisher knock on your door? Like, how did that happen?
Well, I'd have to say that it started early because I've long believed that knowledge is power if it's implemented, if there's something done with that information. And I think it would be so unfortunate for the general population, the public, not to have information about ways that they can take charge of their health and things that can be done, even on an individual basis. Now, this certainly doesn't suggest that there aren't a lot of structural barriers to making lifestyle changes, because this is something else we talk about a lot, that in fact it's not totally equitable in terms of who has access to physical activity, safe parks, safe neighborhoods to walk in, access to nutritious foods, affordable foods. There are a lot of social.
And if you're working 3 jobs, the time to take care of yourself, if your income is dependent on.
There are social determinants of health that are tremendously important. And we actually have recently written an article on this very subject of the importance of behavioral factors, but also social determinants of health, how much they're contributing. But having the knowledge for many people will help them to make better choices about their own health. And that can go such a long way, because if you look at the percentage, we talked earlier, the percentage of these chronic diseases that are preventable, it's really astounding. I mean, we're talking for type 2 diabetes, 80 to 90%, for heart disease, close to 80%, stroke, close to 70%, cancer, close to 40, 50%, dementia, close to 40%. These are really, preventable, highly preventable conditions. Some of it is genetic and some of it is actually not going to be that changeable, but a lot of it is. And I think if people have the knowledge and they have the information, even if it's as simple as we saw in this study, that walking 30 minutes per day was associated with a 40% lower risk of heart attack, coronary heart disease. And many people do find that walking is accessible to
Yes.
them and very inexpensive, just a pair of walking shoes.
Yeah.
And if having that information, which I would often discuss with my own patients, I would write prescriptions for physical activity. And I would very often try to tailor it to what I thought was the right level for them or a good level for them. You know, it was generally 30 minutes per day, but if they had some underlying health conditions, it might start out more as 10 minutes, then gradually build up to 15, 20, you know.
Right.
And with some of them who are really interested in being more active, it would be, you know, for more vigorous exercise
Right.
and a longer duration. But I actually think writing a prescription for physical activity and exercise could be one of the most important prescriptions that a doctor writes all
Right.
day.
Right.
And so there's so much that is within our control, even if everything isn't within, you know, even if there are some examples that we can all come up with where it's just, you know, a lot of disparities and inequities. There are certain things that with the knowledge, you know, certain choices can help to improve health.
And knowledge disparities are as real as any other kind. So I think that, yes, you are addressing social determinants of health when you impart knowledge, right?
Yeah, in some ways, this information that I have prioritized over the decades to talk about, instead of when I get called by a reporter saying, you know, my schedule is kind of busy, I don't think I can do it. I will very often try to find the time because I feel that these media outlets do generally a good job of getting information out to the public, and many people will use that information and it could improve their lives and their health outcomes and their quality of life. And so I've been very open to it. I would have to say that from my earliest years in research, I was being contacted a lot by the media and a lot by women's magazines as well.
Right.
I actually used to do a column, a health column for Glamour magazine, which probably is surprising to you. I'm going to have to.
I saw that and I thought, wow, did you have to have a special photo shoot for that, or how did that go? Oh,
Hold on, my phone is ringing. Hold on.
go ahead. I'll pause.
In fact, I actually used to do a column for Glamour magazine, and it was called The Doctor Is In. And
Right.
I would give advice on a lot of issues across age groups. Some of it was for very young people, even adolescents, you know, related to alcohol and diet and you know, different health problems that they might be concerned about. And I did that for many, many years.
So the readers asked you questions.
The readers would write in questions.
I see.
And I would do a column with the question would be there, and I would provide an answer to the question. And it was a magazine that came out monthly. And it's kind of fun because my kids at the time were teenagers and they would like read. I'd bring home a copy, or they would sometimes like find it in a drugstore and they would say, oh, I was looking to see the last issue to see your column. It was kind of fun. But
you something know, accessible even for your own family, right?
Even if I didn't bring it home. So I thought that being able to provide health-related information across to people across age groups, even very young people who had questions, concerns about different topics, where I thought I might be able to contribute something. I was happy to do it. I mean, of course, these are all things that take some time.
Exactly, yeah.
And some of the research would be of interest to magazines, women's, a lot of the women's magazines were interested in some of the lifestyle factors and things that could be done for improving health or reducing health risks. And
Mhm.
I decided early on that I was going to be receptive to doing interviews of that nature because I just thought it was important to get information out there. It was almost a responsibility.
Right.
If it's information that's usable and could actually be of help to people, they would be able to take charge and actually make a change that could improve their health. I just thought this is a way to get the information out there because so often that information isn't out there.
Yeah.
And so over the years, I have done a lot of interviews. In the last 12 years or so, I've been doing videos for Medscape on
Right.
a lot of topics. It's usually on a more recent publication or article where I think that there's some important clinical message, and I'll do a video on that topic. I've done videos for some other organizations, and I give a lot of grand rounds and presentations. Now it's more virtual than it used to be, but
Right.
give a lot of seminars and talks at conferences. And I have been very open to that, although eventually I am going to have to really reduce the amount that I'm doing because as I try to reduce my schedule a little, that will have not be eliminated completely, but just, kind of dialed down a little.
Right. Right. And I was thinking, did it take the development of a different skill set to speak to these different audiences? Do you mentor your younger, more junior colleagues in this particular role and obligation of scientists? Do you feel that that's important to pass on in some ways, or how do you see that?
Yeah, I think in some ways it's just serving as a role model and they're seeing me do
Okay.
it. I hope that they'll pick it up as well. I think they're often offered opportunities because many of the faculty in our division are doing public health related research, and they're independently getting called by
Right.
media outlets to discuss their work. And I think they've been, from what I've seen, quite open to doing interviews and spreading the word about the findings, especially if it's ready for prime time and
Mhm.
it's something that relates to a modifiable factor, behavioral factor.
Right. Okay. Well, I thought if you have a little time, I will switch gears a little bit. I think we've covered a tremendous arc of a very rich career. I know we could talk for 3 more hours, but I think when I listen to what all you're carrying and doing, I think that that's not a great idea. So I think I'd like to ask just a little bit of a reflexive kinds of questions at the end about the overarching scope of where you've been. One of the questions I always like to ask, when I look at your award, as I'm doing some background research, it's 3 and 5 pages of awards, and I haven't even scratched the surface. I won't ask you about all of them, but is there something that was particularly significant to you, a recognition or an award that you felt I'm really pleased or honored to have received something because it signifies who I understand myself to be, or a reception I didn't know I had? Was there an award or an honor that you want to reflect on? Because there are so many, we couldn't possibly reflect on all of them.
I think first, I'm tremendously honored when I do receive these awards. I always feel really humbled by, being thought of for these awards. I'm often very surprised,
Right.
that I'm told I'm getting this award. I think the ones that have meant a tremendous amount to me, they all mean something to me. So I don't want
I know
to,
when I asked you to reflect like that, I'm putting you in a position, but
yeah,
yes, it's just for brevity. It's not for because you don't think other ones are important.
right, right. I think that some of the recognitions I've gotten from the American Heart Association have been very meaningful to me. I think it's a wonderful organization that does so much, this mission of trying to prevent cardiovascular disease and, obviously puts a lot of emphasis on prevention and getting the word out about prevention. So being honored by the American Heart Association means a lot to me. And I've been very fortunate to have received a number of awards from the AHA, including Distinguished Scientist Award, Population Health, and more recently, Research Achievement Award. So those mean a lot to me. This Renaissance Woman Award from the New York Academy of Medicine, Legacy Women's Foundation, this is also extremely meaningful to me. Over the years, I've seen many recipients of this award. I've gone to their presentations and have had very deep admiration for them and for the importance of the award. So this is personally very impactful and meaningful to me. I think having been elected to the National Academy of Medicine, Institute of Medicine, it has been very important to me in terms of I'm really honored by it. It's an organization that does wonderful work, and I've served on many committees and really tried to contribute to the National Academy, and that it's a recognition or whatever, but it involves service. That's really what it's about. It's not just honorific. So that's been very meaningful to me. I gave a talk at the National Academy of Medicine's conference last year, which focused on women's health. And maybe, I don't know how many to say. I was recently named a Master of the American College of Physicians. That is meaningful to me because of the tremendously important role the ACP plays in physician education, especially internal medicine education. I will mention one other thing, which is a recent award that I'm going to be receiving, the Outstanding Clinical Investigator Award from the Endocrine Society.
Right.
That means a lot to me because that is my specialty, in endocrinology, and to be recognized, for clinical investigation by the Endocrine Society is very meaningful to me. Maybe as a last thing, I'll mention that the Bernadine Healy Award for Visionary Leadership in Women's Health was also very personally meaningful to me because I knew Bernadine Healy quite well. She was the director of the NIH who got the funding for the Women's Health Initiative and the first woman director of NIH. And she was a wonderful person and was so impactful herself. And to get an award in her name was very meaningful to me. So I don't want to go through too many
Right,
awards
but to sort of be included in that sort of
the value
yeah.
of the individual awards.
No, that's a wonderful picture. It helps paint what has been your career and culminations of your career and recognition of that, to be included in that echelon of people in Bernadette Healy's memory or honor is a great testament to what you've done to move the needle on women's health. So I can see that that's meaningful. Okay, so let me ask you to look retrospectively back over your career. I think sometimes, when we talk about achievements, and this has been a career of achievements, I always like to ask people, is there anything you would have done differently? Were there moments of failure that were instructive in some way? Because it can't be success after success. If you look back, would you have done anything differently? Were there points where you questioned what you were doing? What is that side of a career that has been nothing but illustrious, but nevertheless, on a human level, must have had its moments where you wondered, or you now retrospectively would have turned left instead of right, or just asking you to think back over your career and in those kinds of ways?
It's a very tough question. I think that there are many times when I maybe would have somewhat changed the focus of different grants to maybe make them more, fundable. I've had generally very good luck with getting grants funded, but there's always a few areas where
The one that got away. Yeah.
you have, some challenges, and maybe I could have changed direction a little more quickly. Maybe I'll say something about the Women's Health Initiative and the Nurses' Health Study, because I would have wished that some of the research on delving more deeply into the differences by age, time since menopause, some of these factors could have been done really, really early in the process. Though I'm not sure exactly how that would have been done logistically, just because of how complicated everything was at the time, with a trial being stopped early and
Right.
information needing to get out to the public. But I know that there are certain messages that maybe if they could have been delivered even earlier, but there are some natural delays in doing the research, doing all the analyses and getting everything out there. So that might be another example. It's really a tough question. There maybe I can think of a few faculty members I wish I could have even provided them with some additional bridge support, so that, that's always complicated, and
Right.
very often the funding is just not available to do that. But there are some faculty members I've worked with over the years where I've wondered, they may have gone to industry or to a different institution and maybe could have kept them, or provided them with that bridge to help them even more.
Right.
Generally, I have felt pretty good about how things have gone with our faculty and helping to support them in their careers. But I think when you're working with so many faculty members over decades, there will be a few examples where you think you wished you could have done more.
Provide one more thing, right. Yeah.
Yeah.
On a personal level, those are some of the professional decisions you wonder about. On a personal level, would you have done anything differently? The work-life balance that we've talked about, the kinds of things that we've addressed over the course of our interview. Are you happy with the choices you made, and with the personal side of your life and how it's, would you have any advice for someone else about things they might want to think about that you've gleaned from having done it?
I would say that if I could go back, I would have taken more vacation time.
Mm.
And I would have taken more vacation time with my family and with my kids when they were young, even though we did always take some vacation time and doing that. You kind of think back, to all the stresses at the time and how, maybe an additional week off, like not taking all of your, often I would not take all of my vacation time. Of course, we tried to work it out according to their school schedule.
Right.
And so, maybe taking even more time off, having more of those memories of family together, leisure time, taking it easy. I don't have as many memories of that as I might have wanted.
Right.
But,
Right.
I have to say, I haven't heard the kids complain about it. I mean, they do talk about, some of the great vacations, some of the times they really enjoyed being together and going various places. So it probably was okay.
It's
Maybe
not like anyone was harmed by it, but you yourself feel like
yeah, I
would have
think
been
a
richer.
little more time off probably would
Yeah.
have been good. And the last thing might be email. I
Ah,
I really regret how much time I've spent on email. And I mean, I have a pretty good system of dealing with email, but I actually get 550 to 600 emails a day.
a
And,
day. Oh, I can't even imagine.
yeah. And so it's always such a challenge.
Oh,
And there are certain things, I do have different ways of dealing with it, but I try to, I'll start over with that. I try to have certain goals for the day
right.
that I get to before email, maybe
Before you even
sneak
open
on
that,
for
right?
something that might be urgent that I was expecting. But then there are hundreds of emails left to later in the day, and it can become, very challenging.
Oh, I can imagine. And early in your career was before email was a thing, or it was
Yeah, I mean, this
very few
is
people used it.
something since the late 1990s, early 2000, so certainly the really early years of my career, there weren't emails, but there were other, communication.
Communication challenges. Yeah. Other things to eat your time. Uh-huh.
I was getting a lot of voicemail,
Right. Of course, that would have been the thing. Yes.
which in some ways is worse.
More onerous than an
Yeah.
email, which you can afford till later. Yeah.
Or so-and-so
Okay.
needs you to call them back. And then, you have this period during the day that
Telephone
you have
tag.
to leave open for a lot of return phone calls. So I don't know that email has made it that much worse, but I think just the ease of other people, reaching you and sending you questions. And I get a lot of questions from the general public. And so I have various strategies and approaches to deal with this, but it's
One time
always
you'll have to get a talk just on that, because I think many administrators probably struggle with the same problem.
yeah. In some ways, I'd like to go to a talk given by someone else who's figured out
Ah!
how to handle this, but
Okay.
it
A
can be
panel, different people, right?
can be very challenging.
I can imagine. Okay, well, let me ask you a final question, and then we will wrap up our interview and our time together. But I would like to ask you, looking forward, we've talked a little bit about what you thought the significant challenges were today to research, so I won't ask you that again. But given all the vast amounts of mentoring that you've done, what are your hopes and your fears for people coming into the fields of health and preventative health research today? What do you worry about for an upcoming generation or two as they start to move? What do you hope for them, and what do you fear for them?
I hope for a more favorable funding climate so that they're not dealing with many of these struggles that many of them are many of us overall are dealing with, in especially recent years. I also hope that there will be additional approaches, especially for early career faculty, to make their career advancement a little easier. There are training grants, but then once the training grant is over, moving into being fully supported by R01s and these larger grants is very, very challenging.
Like a gap
so
there.
so I hope that there will be more options and a better, funding environment for them. And I think that burnout is a very real concern. And I have seen, especially among clinicians, I have seen so many people struggling with this. And so I really hope that the environment will improve in that regard, where burnout is less of an issue. I think there are a number of strategies in place to help, especially with electronic health records. Things have gotten tougher for clinicians. And I think there are several strategies, approaches being tried out to make things better in that regard. But I think for the physician scientist, it is a real struggle and a real challenge to be juggling clinical work and research. It's not an easy road to hoe. And I think that more help with that, better mentorship in general, and also more resources to help people get through, especially the early training periods. And of course, we talked about funding, but if there could be more public-private partnerships, really good ways to increase, the amount of support available for research and for advancing science, having investigators more easily navigate that system, because so often it's an either or. You go the industry support route, or every NIH route. There are some public-private, partnerships, but I think more in that regard would be very helpful.
Wonderful. Well, I can't thank you enough for a grand tour of a very interesting and intricate career that's worn so many hats and achieved so many things, and to read over and over as I'm preparing for these interviews that you have been, moving the needle on women's health, preventative health in so many different disease categories, and to even hear you talk about what's yet to come as you continue to be chief of the division and to lead these initiatives. It's really been a pleasure for me, just a delight to be able to talk to you and pick your brain about what a life in science and in medicine and in research has really been about. It's been lovely. Thank you so much.
It's been a pleasure for me too, Arlene. I've really enjoyed it. It's really been a trip down memory lane in many ways. It's been interesting and enjoyable. And, I've really enjoyed it. Thank you for taking the time.
Thank you. And I'm thanking you from the Women's in Medicine Legacy Foundation. They will be delighted to be working with your oral history, as will the Countway Library.